thanks, Melissa. I think we're back to me here on our information blocking analysis. And we're still in step 3, but as a quick reminder, and for those that may have joined from the other session, we're walking through an information blocking analysis. And the first step we look at is, does the request for access, exchange, or use involve electronic health information? If it doesn't, we stop the analysis and we look at the privacy rule and your normal request for access. But if it does, we move on to whether or not that request for access is or denial of request for access is that required by law. And if it isn't, then we start to look at whether or not an interference or denial of request for access is permitted under an exception. And we've walked through the preventing harm exception, the privacy exception, and the security exception. And another exception for denying access is the infeasibility exception. So we're asking, is the request for access, use, or exchange infeasible? If it is, if we can answer yes, then the actor can deny that request for access, exchange, or use of EHI. So as with most of these exceptions, they are widely defined. And so to invoke the infeasibility exception, it will not be information blocking if you deny or do not fulfill the request due to the infeasibility of the request. But your practice or that denial must meet one of several conditions. And so it's not just, oh, this is difficult, we don't want to do it, that's not going to be infeasible. It has to meet an uncontrollable event, segmentation, or infeasible under the circumstances. If you invoke this exception, you must provide a written response within 10 days of the receipt of the request, and you must provide the reasons why that request is infeasible. So you can't just say, nope, not going to do it, and ignore it. 10 days later, you've got 10 business days later, you have to provide a written response detailing the reasons for that infeasibility request. So they really tried to put some limitations on it for the fear that a lot of actors or providers will just default to this exception. They didn't want this to be the default exception. So an uncontrollable event, they defined, it's a natural human-made disaster, public health emergency. So, COVID, to the extent that was, that public health emergency could play into play, a public safety event, civil insurrection, internet service interruption is in here as well. So your uncontrollable events, while defined, they are quite broad, and will likely, to the extent that something happens and you can't respond to a request promptly, you should, or the uncontrollable event will be an option. Segmentation is the idea that you cannot unambiguously segment the requested ID or requested EHI from the EHI that cannot be made available. So, the idea that if it's a minor and they want to, and this we'll get into an example of segmentation. One of our example slides, hypothetical slides, include segmentation, which will promptly or easily explain that. Then we have the catch-all. Then feasibility under the circumstances. But again, we can't just say, we think this is kind of infeasible, we don't like it, so therefore infeasible under the circumstances. There are items that you must meet to invoke this particular part of the exception. So you have to have a contemporaneous written record. So again, your documentation, we cannot emphasize enough documentation if you're going to deny a request for access, because it's much easier to remember now and with contemporaneous written record than it is, a year or two down the road once they finally get into the investigation of it. And the infeasibility under the circumstances has to be applied in a consistent and non-discriminatory manner. And you're going to want to give consideration of the type of electronic health information requested, the cost of providing that electronic health information. To the extent that it's difficult to export or something like that, you may be able to invoke it under those. Your financial and technological resources are available. If it's an old EMR system that you don't have great export abilities to, that could be an option as well. And then who owns the technology? If you don't own the technology and cannot change how the export functions or what the features are, that may be a reason for infeasibility under this exception. But essentially, you want a contemporaneous written record of why you can't provide that access, exchange, or use, and that it was applied in a non-discriminatory manner to fall under this piece of the exception. So, as I mentioned earlier, we think these hypotheticals really help articulate how these exceptions apply in real life. And going back to our Zoe hypothetical, who is a minor, visited the clinic for diagnosis and treatment of a venereal disease. She asked that the clinic not discuss her recent visit with her records. Her parents request all of her medical records, not just the ones related to her recent clinic visit. And so we're looking at whether or not the clinic can deny access to the medical records. Again, assuming that the medical records meet the definition of electronic health information, and that we're looking at providing all of the records. We may want to consider the infeasibility exception in this particular point, because if Zoe came to the clinic before she had the treatment for the venereal disease and after and didn't give us any sort of denial of providing the information to her parents or is fine with that, and those STD treatment records are kind of stuck there in the middle, and you can't just easily, take out the treatment for the venereal disease. You may have the infeasibility exception under the segmentation rule, because there's this idea that you cannot give access to all of the records without disclosing the records that Zoe specifically requested not be shared with her parents. That might also come into play if they ask for access to her patient portal, and all that information is in there, and you can't pick and choose what is in the patient portal. You can't say, we don't want the treatment records from August 18th to be in the patient portal. They're all just there. That's where the segmentation rule is looking at helping providers with denying requests for access, because it would result in giving information that they have other reasons for not disclosing. However, as we've discussed before, and we haven't gotten to it yet, but we promised we will get to it, you might need to consider the content and manner exception here, where maybe it's providing her parents with PDF copies of all the records, with the exception of the venereal disease treatment records, or otherwise giving them access or providing those records in some manner that would not violate Zoe's request to not share the information from the venereal disease treatment. Another example of the infeasibility exception is a patient that I don't think we've seen yet. Toby is a patient at the clinic. He submitted a request for his medical records to be sent to him electronically. Last night, before the clinic could complete his request, an E5 tornado destroyed the clinic. It could be several weeks before the clinic's backups are restored and the clinic can respond to Toby's request. What does the clinic do? How do they respond to it? Well, this is an example, of course, of the infeasibility exception, the uncontrollable event, the weather or natural disaster. To the extent the clinic is available or capable, they should respond within 10 days of the receipt of the request, explaining, hey, clinic, E5 tornado destroyed our computers. We're working on getting our backups up and running, but it could be several weeks. We'll keep you posted as best as we can, but it's going to be a little while before we can get you an electronic copy of your medical records. So that's what that infeasibility exception and the uncontrollable event is looking to cover.
Amanda, would another example, I guess maybe the man-made example, would be, a breach, a malware type scenario, where your EMR is essentially encrypted, locked down, you have no access to it. Would that be another example under this infeasibility exception?
I think that would definitely be another example under this infeasibility exception, and one of the reasons why that I think they did define it pretty broadly. You have the telecommunication or internet service interruption part of the uncontrollable event. But I think too, you have the infeasibility under the circumstances where, as long as you're documenting that here's what's going on at the clinic. We've had a cyber attack. We're locked out. We don't know when we're going to get back in. We don't know what's going on. That would be another reasonable. Nobody's going to call that unreasonable denial of access, I don't think. When you yourself can't even access the records, which of course is a scary reality for many people. So moving on to another exception, the fifth and final exception. Again, walking through, we've got EHI. It's not the restriction is not required by law. We have the health IT performance exception. So this is the idea that the health IT is temporarily offline due to maintenance or improvements. If it is, you can deny access, exchange, or use of EHI under that health IT exception. It's the idea that the reason for this exception is ONC's acknowledgement that technology is constantly changing, which means you often have to make it unavailable in order to perform maintenance or improve it or implement new facets of it. And that often may require that your health IT be down, your patient portals be down, any type of remote access also be down. And so if that happens and somebody comes crying to ONC that you blocked their access for information, you're going to have this exception to rely on. But you have to make sure it's unavailable for no longer than necessary to achieve that maintenance or improvements. And it must be consistent and non-discriminatory as implemented, which is a consistent theme. I feel like I sound like a broken record for how often we say consistent and non-discriminatory manner in this presentation, but it is part of this particular exception. In circumstances where health IT is supplied to an actor by maybe a different vendor, that individual or entity must agree to the unavailability of the health IT. And so there's this idea that the final rule did acknowledge that there are times where there's just a blackout for various different reasons that people that understand health IT better than or understand that coding a little bit better than I do understand. But to the extent you can give people notice that the system's going to be down or that there's going to be maintenance on it, so you're not going to have access to it, they want you to provide that advance notice of the system downtime. If you have and this is a bit of a new phenomenon, I think, where you have integration with third-party apps or health providers or actors are providing third-party apps, and that third-party app is negatively impacting the health IT's performance, you can, as an actor, take action against that third-party app as long as that action. So by action, we mean not permit the flow of information into the third-party app, not send information through that third-party app, and really shut down the connection between your EHI and that third party. You can shut that down. You can interfere with, if you will, that access for a period of time that is no longer than necessary to improve or to resolve the negative impacts. Maybe again, you're looking at an increase in pings or security incidents that are giving rise to concern, or there's a lot of glitches. That you're again implementing it in a consistent and non-discriminatory manner, not discriminating against different third-party apps or their purposes. And then two, you want to make sure that it's consistent with any service agreements that you may have with a third-party app or the other individuals that are utilizing that third-party app, whether it be an outside provider of some sort.
All right, so we've worked our way through the 5 exceptions, and none of them applies. So we're looking at step 4, and to see whether any of these exceptions that would apply that would maybe we would still provide access, but maybe not in the way that it's been requested. And so the first one is content and manner, which we've alluded to throughout the presentation. And Amanda mentioned it earlier, up to May 2nd, 2022, you are limited. You don't have to do anything more than disclose the data elements in the US CDI, which I think we've had 2 or 3 slides of all that data. So it's still a lot. After May 2nd, it's all electronic health information, which is electronic protected health information in your designated record set. For purposes of our discussion today, as healthcare providers, most of our requests come from patients. You're providing everything that's being asked for. You're not looking at US CDI. So as a practical matter, I don't think that this really changes how you operate from a day-to-day standpoint. But potentially, if the request came from someone else, not a patient, not a personal representative, potentially you could limit the information, per this rule. Manner. If you fill, if the actor says, I need you to, send me a copy through the portal or by email, and you're able to do so, you should, fill it in the manner requested. If it's not plausible, they're asking for it in some weird electronic format. They're asking for it to be delivered in a way that would not be secure. You can discuss with the individual a different manner, a different format in which to send the information. I I guess, jumped ahead a little bit on that one. So that's this particular slide.
I always call this like the form and format part of HIPAA on steroids.
Yeah, exactly.
But I mean, that's what it is.
Yeah, so essentially, it's tracking with the form and format right to access that we have with respect to HIPAA. All right, so here's our example. Again, we've got a different patient, Claudia Jean, and for those of you that are West Wing fans, you're probably finally picking up on we had Zoe Bartlett, Abby, Toby, and now Claudia Jean, CJ. Amanda and I are West Wing fans. But so here we've got Claudia Jean, and she's requested records from a recent visit. This example is pretty straightforward. It illustrates technically under the information blocking rule, you'd only have to provide the US CDI standard information. But we all know from a HIPAA standpoint, this is a patient. We're going to provide her with the all the information that she wants with respect to her records. The second example relates still Claudia Jean. This time she's asking for the hospital to burn her records to a CD, but the hospital does not have a CD burner. This is an example of the form and format the discussion that we have to do under the HIPAA rules anyways. With Claudia Jean, sorry, we don't have a CD burner, but we can put the information in the patient portal for you. We can email you a copy. We can print off a hard copy. You just discuss with them other potential ways in order to fulfill the request.
It's again the idea that the ONC doesn't want you going out and buying a CD burner just to respond to somebody's request. That's not what they're asking for, but they want you to work with the person requesting to get it to them in a way that works. So then again, still walking through other exceptions that deal with fulfilling a request for access. We walked through the content and manner. Now we're going to look at the fees, because I think one of the most common questions that I still get is, can we still charge fees for requests for access? Well, the answer is yes. And so there's a fees exception for charging fees. But again, much like being able to charge fees under HIPAA, you can't just say, here's what we're charging you. The fees charged must be based on objective and verifiable criteria that are uniformly applied to similar situated classes of persons. So again, this idea that you're probably going to charge a different fee to a patient and maybe no fee to a patient at all for request for access. But if an attorney comes along requesting those records, you're going to charge a fee. And so those different people are uniformly applied to. It is reasonably related to the actor's cost of providing the type, access, and exchange or use. Think reasonable cost-based fee here for the reasonably related. And then two, they were very specific on this. The fee cannot be based on whether the requester or other person is a competitor. So if it's a competing hospital system, you can't charge them $5,000 to access somebody's patient fees. There's, we've seen varying aspects of this, but I think there's this idea from ONC that if there's a competitor, health systems, hospitals, other providers, health IT providers charge exorbitant fees when somebody's a competitor or potential competitor. And whether that's accurate or not is probably varies from time to time, but that's where this fee exception comes in. The fee exception does not apply to fees based in part on the electronic access by an individual or their personal representative. This is the idea that you should not be charging fees for access to a patient portal. And again, it looks at, if anybody remembers, was that 2016 they came out with that guidance in HIPAA on the reasonable cost-based fee.
Right. And
really the underlying piece of that guidance was if it's electronic access to electronic access, you shouldn't be charging fees for it. They've kind of reiterated that position here, where if it's electronic health records and you're giving it electronic access, you shouldn't be charging fees to that individual. The exception also does not apply to a fee to perform an export of the electronic health information via the capability of the certified health IT. So if it's capable of exporting it, you need to really pay attention to the fees for that. If for some reason your health IT provider charges you a fee to export it, then the fees exception is not going to apply. But if they don't charge, you should also look at not passing down that particular charge to someone that's asking you to export it. So to demonstrate our fees exception, Leo represents a clinic patient. He's an attorney. He submitted a request for the patient's records with a valid authorization, requested the records be sent to him by encrypted email via PDF format. The clinic can satisfy this request. Can the clinic charge Leo the fees for providing a copy of the patient record? Yes, they can. But again, the fees have to be based on objective and verifiable criteria to a similarly situated class. So again, similarly charged fees across all attorneys, reasonably related to the cost of providing that type of access. And that's where you're going to get into a lot of, I think there's going to be a lot of dispute here, because if you're sending it via encrypted email, and you're not printing it to paper, you don't have to put it on a CD, you're not putting it on a USB, what fees are you, or what's the cost to the actor of actually providing this? Probably time and labor. Well, we all know under reasonable cost-based fee under HIPAA, there's certain parameters for being able to use that or to charge those fees. So again, the fee exception is going to be one that I think we'll see interplaying both the reasonable cost-based fee under HIPAA and the certain requirements of this fee exception, and trying to interplay with that with a provider's request or providers responding to a request for access. So step number 4, and this is one that we talked about earlier, or I gave the spoiler alert. There's a licensing exception dealing with providing access that permits actors to license the interoperability elements for EHI to be accessed, exchanged, or used. Again, there are certain requirements here for this licensing exception, but the objective of this licensing exception is to allow actors to protect the value of their innovations and charge reasonable royalties related to those innovations, and to get some sort of return on investments that they've made to develop, maintain, and update those innovations. And so that's what this licensing exception is for. There is an expectation that you will negotiate any licensing of an interoperability element And you begin those negotiations within 10 days of receipt of a request, and that you start and you kind of finish those negotiations within 30 days of the receipt from request, if at all possible. Again, you can impose licensing conditions. The idea is that there would be an agreement in place as part of this negotiation of the licensing and that of the licensing exception, and that the licensing agreement or the conditions on the licensing would include some sort of scope of rights, reasonable royalty terms, non-discriminatory terms, and probably some sort of non-disclosure agreement you can have in a licensing exception. And so that, again, they're just trying to help innovators still be allowed to innovate and develop and get some sort of reasonable royalties from that. And so that's where the licensing fee or licensing exception comes into play.
Okay, so let's segue to HIPAA and information blocking, and here what we want to do is try to tie everything together. So how does information blocking mesh gel with HIPAA? So it's important to remember that HIPAA has not changed at all with information blocking. You know, all the HIPAA regulations, exceptions, all still remain in place. I mean, the biggest change, or I guess the biggest shift, is that under HIPAA, you'll recognize if you look through the rule, there's lots of, you know, may disclose. You know, so if you meet the law enforcement exception, it doesn't say shall disclose, it says may. It's a permissible disclosure. So under HIPAA, there's a lot of permissible disclosures that even if an exception is satisfied, you would still, as a provider, have the ability to say, no, I'm just not comfortable disclosing the information. With information blocking rule, what it does is it now requires that disclosure. So if you meet the subpoena, for example, the subpoena exception under HIPAA, you know, before you could still say, yeah, no, I'm just not comfortable disclosing the information. What information blocking rule says now is, well, okay, you meet that HIPAA exception for subpoena, you have to disclose the information. Next slide, Amanda, please. And so this just kind of is another way of looking at that. You know, the HIPAA, a lot of the disclosures were may, and with information blocking rule, you must share the information. This next slide contains, I think, a really helpful side-by-side comparison of, you know, how HIPAA matches up with information blocking. And so these next two slides, you know, I'm not going to, we've already kind of gone through some of these things, but this is a really good take-home slide or two that really demonstrates the differences and the similarities between HIPAA and information blocking. So with that, I think, oh, go ahead, Amanda.
I was going to say, I mean, the ONC acknowledged, and the exact quote is that the interplay between the information blocking rule and HIPAA is inherently complex. That's super helpful that they've acknowledged that. But I know there's been some push for further clarification, further guidance on how these two rules actually interplay. But for what we have now, this chart is kind of the best demonstration of similarities, differences, how they kind of interplay with each other. And with that, I think I'm going into preparing for implementation, patient portals, lab results, and draft clinical notes. This section really gets to heart, I think, some of the common questions that we've been receiving, some of the FAQs that ONC has articulated to help providers with implementing the information blocking rule. And so we're going to walk through a couple of these using some examples again, because that's usually the best way to understand some of these things. So Donna recently visited the clinic for her annual physical. The clinic is the clinic required to proactively make the electronic health information from that visit available through the patient portal? And the answer to this is no. There's no requirement in the information blocking rule that a provider make the information proactively available on the patient portal. Again, it's important to remember that information blocking is invoked when there's a request for access, exchange, or use. So that is the world that we're living in, is that there are requests. It's how you are responding to a request. So so that you don't have to make things proactively available to patients. You don't want to delay any release of that information in response to a request, but there's no proactive requirement. The same for patient portals and lab results. Labs were obtained in that recent visit. Are they expected to release the lab results to Donna as soon as they are available to the ordering clinician? Again, no, there's no proactive requirement, but once she requests that access, the clinic has to timely respond to her request. So there can't be any delay or other unnecessary impediments on providing that access once they ask for it. Now, I think most providers, or at least I know, I've been able to, I'll go to the doctor, and probably a couple of days later or a week or two later, I'll get an email, hey, your patient portal has been updated. That's still great practice. But again, there's no requirement that it be made available as soon as it's available to the ordering physician. Sticking with lab results here, we had labs were attained. Donna's got a primary care physician and an oncologist. The oncologist contacted the clinic to request the labs, but the lab results are pending confirmation. So, you've got the results, but they aren't confirmed yet. Should or must the clinic release the lab results in response to the oncologist request? This is the classic "it depends" answer. The laboratory results pending confirmation is an example of a data point in the USCDI standard, and it may not be appropriate to disclose or exchange until those lab results are final if they're trying to run another confirmation test or something. And it kind of gets into this idea of inaccurate information or the preventing harm exception. But where ONC is advised, they're going to want to see you make those available promptly in response to a request if those results are going to be used to make healthcare decisions. So if you've gotten lab results back and it shows that someone has an elevated thyroid level, and then you've gone and prescribed them medication already, but you're still waiting on confirmation, or they aren't finalized yet, or something along those lines, you still need to exchange that information or provide access to that information because it's being used to make healthcare decisions. Again, the heart of, or the reason why the 21st Century Cures Act was implemented, the reason behind this information blocking rule is to help promote the exchange of information to allow individuals to be active in their making their health care decisions. There's this idea that there's a restriction of flow of information from provider to provider, which gives ONC heartburn. And so the common theme here is going to be if you're using that data element, if you are using that information to make healthcare decisions about the patient, ONC is going to want to see you exchange that information as quickly as reasonably possible. Otherwise, it could be violating the information blocking rule. Again, more draft or at least draft clinical notes. So the clinician's notes for Donna are in the medical record, but they're in draft form. They're not final. Is that included in the definition of EHI? Draft clinical notes pending confirmation is another example of this data point that may not be appropriate to disclose or exchange until it's finalized. The clinician may need to add more to it, may need to clarify. And so it's really going to depend. But it's one of those things that you should encourage your clinicians to finalize notes as soon as possible, because notes are often used in healthcare decisions and making healthcare decisions. And so the ONC is going to want to see that exchanged as quickly as possible. Again, some common themes here with draft clinical notes and lab results. ONC was very clear in the final rule and in their FAQs that you cannot delay fulfilling a request because you know there's going to be more EHI for that patient available at a later date. If you have parts of it now, they want it uploaded, they want it exchanged, and so you cannot hold on to something because you know you've got the draft clinical notes, but you know lab results are coming later. You can't hang on to it until you have everything to turn it over. Probably not the most ideal thing for all of us that like to have everything turned over in one nice pretty little package with a bow on top, but that's what that is what they advise. The incompleteness of a patient record does not render the rest of that record inaccurate. So again, getting into this idea that even though you know there's going to be more later, just because it's incomplete doesn't mean you can deny. It's not a reasonable basis on its face to deny that access or exchange or use. Now, there may be other reasons for it, maybe thinking preventing harm exception here, but make sure you're walking through the analysis and it's not simply because the record is incomplete, therefore preventing harm. You also want to look at organizational policies that impose delays on the release of information to allow a clinician to review or personally inform the patient of the information. If that's a policy that may, again, it isn't automatically considered to be interference with, but it may be considered interference with if the policy is without fail, we're allowing a clinician to review and personally inform the patient. But at the same time, there's certainly going to be times in which hanging on to that information, delaying the release of that information is reasonable and necessary for the proper care of the patient, to allow the clinician to personally inform the patient of results. Thinking of some sort of cancer diagnosis or something along those lines that may be more proper to inform the patient. Another example of an organizational policy or a reason where imposing a delay may be appropriate is one of those preventing harm exceptions where there's domestic abuse and that there may be issues if a significant other gets a hold of information. Paper records, we talked about paper records a little bit throughout this entire presentation, but as a provider required to fulfill a request with all the EHI they have for a patient, again, paper, information blocking only applies to electronic health information. If there's paper records that are kept but not maintained electronically, you're still subject to HIPAA, so you're going to have to look at that. But the information blocking rule doesn't govern paper records. So to close out today, we wanted to talk through some organizational impacts of how to review this and implement it at your organizations. The first thing you're going to want to look at is if you're a covered actor, keeping in mind that you may fit under more than one definition based on the rules of your facility. But again, healthcare provider, broadly defined. If you're a healthcare provider, you're an actor. Look at all your connection points to your electronic health information, identify the different areas of risk. You may have ultrasounds, you may have CT scanners, all these different points of EHI that interplay, and make sure that you've done your risk assessment. How do you currently share that information? If you don't share it, why isn't it shared? Looking at all those different ideas for how information is exchanged and used. And when you identify those areas, you want to assess them for functional capabilities. Maybe something can't be exported or exported. Control over the information. I mean, do you have control over how that stuff is exported? Look at your policies and procedures, look at your fee structures, and begin this process of acknowledging where information is, how it's exchanged, and potentially revising those policies and procedures to alleviate risk of violation of the information blocking rule going forward. These are some inherently suspect practices that were outlined both under the proposed rule and final rule. These are common sense, to be entirely honest with you. The interference they hit on the things that we were like, well, of course that's interference with, of course that's a violation. Providing patients with access to their EHI and the ability to exchange and use it without special effort. If you you interfere with that, I mean, that's going to be information blocking. So this is just to give you some ideas of, what type of practices that hopefully most people are not engaging with in any way that will be considered to be inherently suspect. I spent a lot of time talking about the fees in the fees exception, but the ONC has said that the practice of charging an individual or their personal representative fees for electronic access to electronic health information is going to be inherently suspect. This should not cause heartburn. I would hope it doesn't cause heartburn to anybody because of that 2016 final rule or that 2016 guidance under HIPAA. But again, just really watch what fees you're charging. They've got to be compliant with the HIPAA patient access rule, that reasonable cost-based fee analysis. And if you're going to charge costs, make sure you're maintaining those cost records and documenting how you reached that cost of charging it.
Preconditions to access, we've talked about this a little bit. Essentially, you're not prohibited from having practices in place to verify the identity of a patient or their personal representative, which is similar again to the concept under the HIPAA frequently asked questions that were issued in 2016, which said that you're not creating an unreasonable barrier to access if you're asking folks to verify they are who they say they are when they're asking for access to information. I mean, the important thing is, and that's going to vary depending on the situation. So you may ask for different information to verify when you're taking that request over the telephone versus somebody that's standing in front of you in your HIM department. Also, preconditions to access, we talked about HIPAA compliant authorizations. You're required to make a reasonable effort to get that patient authorization, but you're not required to chase the patient to force them to sign an authorization. If you make a good faith effort and the patient's not inclined to sign the authorization so that you can disclose the information in response to subpoena to the attorney, then you've complied with the requirements under the information blocking rule.
Preventing harm. I spent a lot of time talking about the preventing harm exception. And I think one thing I said was that the ONC aligned the preventing harm exception to align with the preventing harm standard under HIPAA. So, because they really adopted that and implemented that, you want to review any existing patient access policies with regard to denial for preventing harm, make sure that they comply. It's a good opportunity to review and ensure that it's conforming also with that preventing harm exception conditions and requirements. Regarding minors, we did have a lot of hypos today with minors, and I think that's because that's been where I've gotten a lot of information blocking questions. Parental access to EHI of minors can consist of different types of healthcare. You want to identify who has access, who's been permitted access. Look at your state laws as to when a minor can independently consent, and then look at that infeasibility exception. If for some reason you cannot effectively segment or safely or permissively share that information, and make sure that you're confirming the representative's legal authority to access the minor's EHI when you provide it to them. Interference versus education. The ONC was pretty good about explaining that educating patients about privacy and security risks is not interference with. So you can educate patients on privacy and security risks. The fact that a third-party app may not be the best way for us to send them information. That education does need to be factually accurate and unbiased, and applied in a non-discriminatory manner, consistent, focused on security risks. But ultimately, as we all know, the patient has the ability to dictate where their information goes. And if they still, after this education, want to use a third-party app, want to use an unsecure way of exchanging that information, the actor should respond to that request and provide that information. It's like the encrypted email. If the patient doesn't want to receive the information via encrypted email, and they've said that, you've documented it, you can send electronic health information in a non-encrypted format. Contracts and agreements. you just want to start reviewing some of your data use agreements, remote access agreements for unconscionable terms regarding access, exchange, and use, and licensing of that interoperability element, just making sure that that those don't have any sort of impermissible fees or items that are not unreasonable.
With business associate agreements, the key here is, as a covered entity, healthcare providers are going to have these agreements in place with their business associates. You can't insert language into your business associate agreements that would prevent your business associates from granting access or exchanging or using electronic health information. For example, you couldn't have a provision in there that says, business associate, you can't release any information to our hospital competitor. And so just kind of keep that in mind. If you as a healthcare provider can't information block, you can't ask your business associates to do that on your behalf. This next slide is some helpful information. I mean, by and large, we didn't see a need to update our business associate agreements with respect to the information blocking rule. But Amanda and I did develop this language that you can kind of stick at the end of your business associate agreement that just acknowledges both parties are aware of the information blocking rule and that it's their intent to comply with the information blocking rule. And if there happens to be a provision in the business associate agreement that would be considered to be in violation, that the parties are acting in compliance and will make the necessary amendments in the event that becomes necessary. And then the last thing before we are about ready to wrap up, I know we're a couple minutes over and we've got a couple slides with takeaways, just related to the HIPAA security risk assessment and the security exception, making sure that you're completing that HIPAA security risk assessment. You need it for information blocking, and you also need it for your HIPAA security compliance. We recommend creating that IT asset inventory, anywhere you might have electronic health information stored, that you have an inventory so you understand the ultrasounds and the CT scanners and all the pieces of equipment outside of your EMR that may have protected health information. And HHS and ONC developed a HIPAA security risk assessment tool. So if you go to healthit.gov, there is a security risk assessment tool that you can use. It's promoted for small physician practices, but I think, and I encourage all provider types to use it because it's a very user-friendly, asks you the questions, you say yes, it takes you off to a different question, you say no, it takes you down a different path, and it's really a good way to complete your security risk assessment. So with that, we've got a few take-home points that just keep in mind information blocking is not just an IT issue. It's a complex area. It's a evolving area law. I mean, we still don't even know how the penalty piece of this is going to work. So keep that in mind, that it's an area that's in flux. And as things go forward, we'll probably be seeing additional guidance coming from ONC and perhaps even the Office for Civil Rights, the arm of HHS that does the HIPAA investigations. Review your existing privacy and security policies from a HIPAA standpoint and update accordingly just to reference information blocking, privacy, and security exceptions. And consider updating your business associate agreement and other important documents. My final thoughts on this before we leave you would be that you remember, just because you don't meet one of the 5 exceptions doesn't mean that it's a per se violation of the information blocking rule. Remember what Amanda said, it's fact-based, based on the circumstances. It's very much like an anti-kickback analysis. We want to try to fit into one of the safe harbors because that gives us the, yes, we meet the privacy exception or security exception. But just because we can't get something to fit in that structure doesn't mean that we per se have a violation. And the second point I'd like to leave you with is just, with respect to this whole HIPAA, versus information blocking, that when we were dealing with HIPAA, it kind of the thought was, well, when in doubt, don't disclose. Like if we're iffy on whether we're meeting an exception under HIPAA, let's just defer to not disclosing, so we're not in a situation where we violated HIPAA. Now, the paradigm has kind of shifted to that you will disclose unless you meet one of the exceptions. So you just kind of keep that in mind. Make sure you're documenting, as Amanda stressed during the presentation, when you're trying to rely on these exceptions, and documenting those communications with patients and others who are requesting access to information. Amanda, do you have any parting thoughts to add?
Yeah, the third parting thought I was going to add is, make sure you are documenting, because again, this is an emerging area. Documentation is going to be important as you try and establish this is how we walked through something. The ONC was very adamant that this is going to be a fact-based circumstances. They're going to be looking at all those individual facts and circumstances when they're analyzing the violation of the information blocking rule. And so documentation will be key and important. And then the other thing is just make sure you're training your staff, both your HIM individuals, the people that are dealing with those requests for access into this, mental and paradigm shift from this may disclose to shall disclose. It doesn't need to be scary. It's just going to be a different way of thinking. The other thing that I would encourage everybody to go to is the ONC information blocking website has got a lot of information on it. Fact sheets, FAQs, they are updating those FAQs a little bit here and there. And so we will be going there, or here's a link to that website. Brooke, do you want to introduce the help?
Oh, sure. Just our parting comments. If you liked, I guess, what you heard from Amanda and me, we put on a Health Law Institute for our Kansas and Missouri healthcare providers. Stay tuned. That's coming in October. We've got a link on this slide if you would like more information. We cover a variety of topics, including compliance and HIPAA and anti-kickback and Stark Law. It's really intended to educate all kinds of healthcare providers, large and small hospitals, clinics, with respect to that kind of the hot issues that we're seeing with respect to healthcare regulatory issues. And we will make the slides available after the presentation. So those will, I think we'll send them to Melissa, and Melissa will get that sent out to the group. We appreciate your time and attention today and giving us